we are going to get started on this teaching session. This is a part two, basics of HIV science and care. Um, I was trying to make it like a 201, like more advanced, but it's not really. It's more like a 102. So I called it HIV 102. So I will be going over some of the pieces of part one because I think some of you didn't hear part one, although I think part one is recorded. So you can have a look at that at the Women's Centered HIV Care Hub YouTube channel. But I will go over HIV 101 content briefly, and then we're going to try to get into some more advanced information. And so I'm really excited. And I'd like to start with a land acknowledgement that we acknowledge all the ancestral traditional territories and lands and waters across where we work, play, live, and learn. I live and work and raise my family and hang out with my friends in Toronto, which is covered by Treaty 13 with Mississaugas of the Credit First Nation. And so we're going to go over a little bit about the biology and science of HIV, a bit about the clinical manifestations and care of patients living with HIV. And then we're going to go over more about antiretroviral therapy, which we didn't get to in part one, HIV 101. So I wanted to spend more time talking about antiretroviral therapy. And actually, I added a piece about pregnancy. So we'll go over that also. So in terms of the virology of HIV, I think you might not know this, but there's actually two different types of HIV virus. So I don't know if you know that. That's so cool in my mind. The one that we mostly talk about and do research, health research related to is HIV-1. That's the more common one. And HIV-2 is a different virus. And they actually came from different sources. The HIV-1 came from the chimpanzee, HIV-2 came from the pseudobee monkey, and they originated in different regions. If you want to read more about it, there's an incredible book called The Origins of AIDS by Dr. Jacques Papin from University of Sherbrooke. I highly recommend it. And in the HIV-1 actually also then gets divided into different subtypes. There's many different subtypes of HIV-1. And the other word for subtype is clade. So there's different clades. So that would be A, B, C, D, E, F, G clade. And then they can recombinate. So you can have like AE clade, AFG. So they can recombinate. So that would mean that one person was infected with a clade A virus and another and also a clade E virus, and the virus recombinated to form a clade like AE. It's relevant because the HIV-1 and HIV-2 have different disease progression. HIV-2 is a very slowly progressing virus, so it doesn't erode the immune system as fast or at all. And while HIV-1 depletes the CD4 cells much faster. And then the clades themselves also have different progression and some different issues and even some of the HIV-2, for example, doesn't respond to some antiretroviral drugs. So then we can't use, for example, NNRTIs. And similarly, there's some clade issues when it comes to antiretroviral drugs, which is interesting. Clade A, of course, was the first clade of HIV-1 and started in Africa. And it is no longer the most common clade in the world. Now it's clade C, and that again is in Africa. And that's actually because clade C has a slower progression. So clade A killed its host. A virus doesn't want to kill its host, actually. So HIV virus is not an ideal virus because it kills its host. So viruses, HIV clades that are more slowly progressive are going to be transmitted more commonly. So then that's why clade C uh, is more common now. And what happened is for some reason, we don't know why, but it was a clade B virus that came to North America and Europe. So in Canada, the United States, Mexico, even South America, and in Europe, we have we have clade B virus. Why? We don't necessarily know. There's theories, and it's in that book I told you about. And why that becomes relevant is when we test for the HIV viral load in the lab. I don't know if anyone is planning to be a laboratory scientist, but this will take you back to your first year biology. That when we measure the HIV viral load, in the laboratory, we use PCR. Remember that? A polymerase chain reaction. And we have to use primers. We have to use primers for that PCR. And so in North America, the primers are specific to clade B virus. And so sometimes what happens actually is if you're seeing a patient who comes from Africa and they have non-clade B virus, the HIV viral load test that we have might not detect their viral load. And it might be a false low viral load. So that's something a little bit interesting. The HIV virus is an RNA virus. So most viruses are RNA viruses, but about 20% are DNA viruses. It's an RNA virus. It has two strands of RNA. RNA viruses are easier to kill. So that's why the HIV virus, like you can't get it from kissing, or you can't get it from an inanimate object because it actually dies very quickly as a RNA virus. Oh, I mean, and it's also an envelope virus. So it has an envelope, so the envelope breaks very easily. And then HIV is a retrovirus. So it has its own enzyme uh, called reverse transcriptase that assists with its replication. So, um, so that makes it a more advanced virus than other viruses. Other viruses 100% have to rely on the host machinery to replicate, but HIV has reverse transcriptase that helps make copies of itself, which puts in the the nucleotides. It's again an envelope virus, and it's actually that part that makes it easy to kill because you just put bleach on it or alcohol or anything, and it breaks the envelope and dies right away. And it's a capsid, um, and it has other enzymes, specifically protease and integrase. And that becomes important because we're going to spend a bit of time talking about antiretroviral therapy. And this is the life cycle of the virus. So the different drugs used to treat HIV, they are aimed completely at blocking replication. So understanding the replicative cycle becomes important. So you can see there's the virus under the one that looks like a circle with knobs on the outside. Those knobs on the outside are the glycoprotein 120. And that through the glycoprotein 120, it binds. You see there, the yellow stick is the CD4 receptor. So the virus through GP 120 has to bind only to the CD4 receptor And that CD4 receptor is only on a few cells. It's on the CD4 T lymphocyte, it's on macrophages, and it's on some cells in the brain, like the glial cells. And so those are the only cells that can get infected with HIV. And then there's a conformational change after binding. There's also, we discovered in the early 2000s that it also binds not just to the CD4 cell, but it also binds there's a second binding site, which is a chemokine receptor that where it binds to, which can be CCR5 or CXCR4. It needs to bind to both. And then there's a conformational change where this needle comes out from GP120 called GP41. And then together the GP120, GP41 make GP160, or I guess 161, but to make it easy, 160. And that GP41 is like a needle, pierces the cell wall of the CD4 cell, and the envelope of the HIV virus merges with the cell wall of the cell membrane. And then you can see there that the RNA is released, RNA plus reverse transcriptase. The reverse transcriptase converts the RNA to DNA, and then that's called proviral DNA. That proviral DNA goes into the nucleus. It gets integrated into the human or host DNA, and then the reverse transcriptase makes millions of copies from that with reverse transcriptase. So you can see the new sort of blue RNA there, and then the protease enzyme and the integrase enzyme. The RNA gets transcribed or gets translated into proteins, and then it gets cut up by protease. The integrase is involved with the integration into the human DNA. And then all of that is made, and then the virus kicks out of the cell. And it takes actually the cell wall to make its envelope. And so that's part of the reason why it's been so hard to make an HIV vaccine, because the envelope of the HIV virus actually comes from the human cell. So it's not detected as foreign. Okay, so that becomes important when we're going to talk about drugs, because what you're going to see is you need to have at least 2 drugs to treat HIV, and they have to work at different parts of this replicative cycle. Do you see that? So, and then for many years, for decades, we used 3 drugs that worked at 2 different sites of the replicative cycle. Like we did studies in the early days where we had 3 drugs from the same replicative cycle section. 3 drugs from the same replicative action doesn't work. You need 2 or 3 drugs from 2 different parts of the replicative cycle that are blocking replication at 2 different sites. And interestingly, I can ask you, well, how many do you need to prevent HIV? Right? So actually, for people who've come to who've seen PrEP patients with me, you'll have seen that we can use cabotegravir or Lenacapravir to prevent HIV. So technically, you only need 1 drug. Do you see that? To prevent HIV, or 2 drugs like as in Truvada or Descovy, which is TDF FTC or TAF FTC. So you need 1 or 2 drugs to prevent HIV, but on only 1 site, but you need 2 or 3 drugs working at 2 different replicative sites to treat HIV. These are the modes of transmission. Primary mode is through condomless sexual contact. That can be heterosexual, same sex, does it, it's really just it's sexual contact without a condom. So you might know or not know, we don't use the term unprotected anymore. We don't say unprotected sex. We say condomless sex because sex can be protected by PrEP or PEP or other means. So we say condomless sex and anal sex. So receptive anal sex has the highest mode of acquisition, uh, receptive anal, and then insertive anal and insertive vaginal. Um, and then next is a receptive vaginal, then insertive anal, insertive uh, vaginal, and then uh, there have been cases of transmission through oral sex, but they were in the very early days of the HIV epidemic, in big in big cohort analyses where people report the only sex they reported was oral sex. So it is our understanding that HIV is very, very extremely rarely and actually to a negligible amount transmitted through oral sex. And then the second mode is through blood, parenteral contact. So with intravenous drug use, it's not the intravenous or the drug use, but it's that the supplies that are being used have blood on them. And it's the exchange of blood. That's the issue. Needle stick injury, blood transfusion. And then what we call vertical transmission or perinatal transmission. That is the transmission from a person who's pregnant to their infant. Okay, any questions about that before I go on? It's okay. Okay. This is what we call the natural history of HIV infection. I know it's a really complicated slide, but this is how it is a bit complicated, so I'm not going to minimize that. But I want you to first look at the line that has the triangles. Do you see that? It's kind of like a hatched line with the triangles. And actually, the line with the circles is also the same. They're both pretty much the same. It's culturable plasma viremia or the HIV RNA copies, which is the viral load. So after somebody acquires HIV or gets infected with HIV, which is primarily through sex, and understanding actually how the actual infection happens in in the genital tissue is not very well understood. If we have anybody here who's really into basic science, that's a really cool field, is to research how the actual virus goes from like a genital secretion into the cell. Do you see what I mean? And it's believed that it's to macrophages in the genital tissue. And so then that happens. Then the virus is making copies of itself and then infects other cells. But you can see it takes 2 to 6 weeks, 8 weeks for the viral burden to go very high, right? But then by about 6 weeks, the viral burden is about like over 1 million copies per milliliter for the viral load. Do you see that? So when somebody gets infected with HIV, they don't get sick right away. They it the sickness happens after a week or 2 or 3 weeks. And what do they get? Well, it's a virus. So they get a flu-like illness. And what percentage of people get this kind of flu-like illness after acquiring HIV? It's in the order of 50 to 80%. So actually the majority of the people, if you ask them, do you remember a time where you felt really, really sick? Like you couldn't get out of bed, you had a fever, you were so tired. couldn't get out of bed, lymph nodes are swollen, you get sore throat, a cough, maybe even like heartburn, um, and sweats. What's strange is people don't think it's HIV. Do you see that? Like you just think it's a flu, it's the cold, it's a cold. Um, um, but that is called acute HIV, or also known as acute seroconversion illness. HIV being neurotropic, I told you that it can bind to cells in the brain, glial cells. You can actually get neurological manifestations in the acute HIV infection, like Guillain-Barré, Bell's palsy, um, and then you can also get a rash. It's like this fine rash that you can get. But the rash only happens like in 20% of people. So that's the acute infection. And then what happens is the person's body is able to suppress the virus itself. And if you remember, the cell that uh, kills viruses and suppresses viruses is called the cytotoxic T cell, the CD8 cell. So you can see there at about week 7, 8, the cytotoxic T cells are activated and they're suppressing the viral load. So the actual person's body is able to suppress the viral load and control the virus. And so you can see that the viral load, which is the uh, uh, the section, like the triangles, goes down to about, you can see like it there, it looks like it's at about 1,000. We call that then the HIV viral load set point. And that set point determines how fast the HIV disease will progress. So on average, if the and on average, if the set point is around 10 to 50,000 copies per milliliter, that would be standard. Then you can see the line that has the squares. Do you see that line with the squares? That line is the CD4 count. So a person's like usual CD4 count is about 1,000 cells per millimeter cubed. And then it goes down significantly in acute infection. And we say that a CD4 count above 500 is a preserved immune system, but it's still not completely normal. A CD4 count really in the 900, 1,000 range, even 1,200, 1,500 is normal. And then after the virus is suppressed a bit by the cytotoxic T cells, the CD4 count blips up a little bit. But without treatment, the CD4 count falls by about 50 to 75 cells per year. So then if you do the math to go from 500 to about 0, it takes about 8 to 10 years. So without treatment, on average, a person would die after 8 to 10 years. And so here you go. I went over that with acute HIV infection. And the progression is usually 8 to 10 to 12 years. And but not, that's an intermediate progressor. You see that, and that's like the example in the middle. But sometimes we have cases where there's like rapid progression, where for some reason the virus will suppress the CD4 count really quickly and kill the CD4 cells, and the person progresses more rapidly. Or you can see on the bottom there's about 10% of people who are late progressors, whereby for some reason the virus might remain low and the CD4 count remains high. We have cases where the viral load is undetectable without any treatment. Those are called non-progressors. Or if they're a long-term non-progressor, that means that would have happened for years. And then if that's happened where the viral load is undetectable and the CD4 count doesn't fall for over 7 years, they're called an elite long-term non-progressor. And there's like genetic reasons why those happen. And you've heard of the cases of the cures of HIV. Those have all happened because people who had hematologic cancers or different cancers had bone marrow transplants. So people who had cancer, who they were living with HIV and had cancers, they had bone marrow transplants from people who had genetic reasons to be an elite long-term non-progressor. Because in a bone marrow transplant, you wipe out every white cell in the body. That's why it has like such a high risk of high mortality. And then they got a bone marrow transplant with somebody who has um, a genetic mutation that causes them to be an elite long-term non-progressor. And then they're cured because every white cell is replaced. Okay, so here is the the uh the how advanced someone's HIV is based on the CD4 count. So we say that if it's greater than 500, it's normal. If it's between 200 and 500, it's mildly decreased. I would say mildly decreased is more like 350 to 500. If it's less than 200, it means that there's significant immuno uh, suppression, and less than 200 is really like our worry zone. Like that's when we worry people are going to get pneumonias and different diseases to end up in hospital. And those diseases are called opportunistic diseases or opportunistic infections because they have the opportunity to grow uh, with a suppressed immune system. And then if someone's CD4 count goes below 50, then it's severe immunosuppression, and they would have their life expectancy would be like a year. And so that's important for you to know when you've come to clinic with me and we've seen some people with different CD4 counts. And if they have a low CD4 count and I'm freaking out, this is why. And so opportunistic infections or diseases happen based on the CD4 count. So these ones here are not considered um, what we would call AIDS-defining illnesses. So to be diagnosed with AIDS in Canada is not the same as having HIV. So most people living with HIV have HIV virus, and we say they're living with HIV. Someone has AIDS when their CD4 count has gone low enough and that they've acquired an opportunistic infection or opportunistic disease. And there's a list of AIDS defining illnesses that classify uh, that are classified as AIDS related conditions. And it's only when you have one of those that you technically are classified to have had AIDS. Do you see that? And it's really just used for public health purposes, like for counting, like how many people have HIV, how many people have AIDS. Because the more people who meet the criteria for AIDS, well, then we're not doing as good a job at capturing them early enough to start them on antiretroviral therapy. These are not AIDS-defining illnesses. So someone might present with irretractable candidiasis. So like someone with a vagina could have like vaginal candidiasis and it just won't go away. So that might be a signal to test for HIV. Herpes simplex, shingles in a young person. You know, it can happen from stress, but it can also happen from HIV. And you can have co-infections with something like syphilis. When the CD4 count goes below 200, that's when the more serious opportunistic infections happen. You get oral thrush, so a candida, which is yeast in the mouth, and that becomes worrisome. Oral thrush in itself, I think I have a picture. This is a patient with oral thrush. This is what it looks like. Is not an AIDS defining illness. What is an AIDS defining illness with candidiasis is if the candida goes down into the esophagus, that's called esophageal candidiasis. and that I often will just diagnose it on speculation, because they have what's called dynophagia, which is it's painful to swallow. If they say it's painful to eat and swallow, and their mouth looks like that, or they even maybe it doesn't, then it's esophageal candidiasis, and that's an AIDS defining illness. PJP is pneumocystis, I think it's next. Jirovecii pneumonia. It's the most common opportunistic infection, and it is I think fungus now. It's considered a fungus, and it causes this like chronic pneumonia or subacute pneumonia, and it's the most common cause of death, actually, if HIV goes untreated, because it's actually a little bit similar to COVID, whereby it causes like an inflammatory response in the lungs, and actually can be treated with steroids. And it causes hypoxia, low oxygen, and it can cause pneumothorax. Kaposi sarcoma is caused by actually a virus, HHV8, human herpes virus 8. So if you saw the movie Philadelphia, in that movie, the lawyer had Kaposi sarcoma. When the CD4 count goes below 50, there are other, when it goes below 100, the second most common opportunistic infection is cryptococcal meningitis. So we'll see that. That is a fungus. And a lot of these, like toxoplasmosis is a parasite, CMV is a virus. And a lot of these, they're not like the person gets newly infected. They're actually, the person's already infected, but with a strong immune system, it doesn't cause disease. So what happens is the CD4 count goes down, and then now the CD4 count is low enough, the immune system's low enough that these fungi and parasites like emerge and become uncontrolled. So, and Mycobacterium avium complex and CNS lymphoma. So that's why I say opportunistic infections and diseases, because it's not only opportunistic infections like toxo, CMV, MAC, also diseases like cancers, like a CNS lymphoma, is also an opportunistic disease. It is actually associated with an infection, which is EBV, Epstein-Barr virus. So this is what CNS toxoplasmosis looks like. It's a parasite, and it causes these brain abscesses. Do you see that? And it's multifocal. So you can see a big one on the right side, and you see like a small one in the left in the back. And because they're like masses, people will present with seizures, actually. These are all treatable, so you can treat them with antifungals or antiparasitic or antibiotics. But the key is to get people started on antiretroviral therapy. So we already talked a little bit about the viral load. So we do viral load testing, and we measure the amount of RNA in the blood. There's different ways that it can be tested. And then we measure the CD4 count. So when I'm doing counseling with a patient, I'll let them know, but we want to know what the viral load is. You're going to want to ask me, what's my viral load and what's my CD4 count? The main goal is to have the viral load to undetectable and the CD4 count as high as possible. After starting antiretroviral drugs, the CD4 count can actually continue to go up for 5 years. But once the CD4 count is above 200, there's really no point on doing it. So it costs about $100 or $200 to do a CD4 count. So good practices is actually to stop doing the CD4 count, and we only really care that the viral load is undetectable. There are some other parts of the immunologic markers that we can look at if you come to clinic with me, and I can show you. It's kind of interesting that the CD4 count is just actually a very narrow window into the immune system, that actually the CD4 count can be 500, but the immune system is still significantly impacted. And you can see that a little bit more if you look at the CD4 percentage, CD4 to CD8 ratio, total lymphocyte count. Okay, that is HIV 101, which some of you have heard before. And so we're going to go on to talk about antiretroviral treatment. Any questions about that before we go on? About sort of like the background, we went over some of the biology, the clinical manifestations, how we do testing of viral load and the immune system. Everyone's good so far? Okay. Antiretroviral treatment. Look at this. These are the first antiretroviral drug classes. So the first class of drugs that came out are their NRTIs, nucleoside reverse transcriptase inhibitors. And it's a bit confusing because each drug has a generic name. So like abacavir, and then um, and then they would have a trade name. So abacavir's trade name is Zyogen, for example. And then if you're looking through charts, there's a three-letter abbreviation. And if you're looking through charts, there's the correct three-letter abbreviation, and then there might be like the wrong one. Like maybe someone would call abacavir ABV, right? So you have a generic name, a trade name, the correct three-letter abbreviation, the wrong three-letter abbreviation, and some drugs have the experimental name. So it's a lot of names for the same drug. But besides that, the most important thing to know is the generic name. These are the generic names and the three-letter abbreviation. So the first class to come out is reverse transcriptase inhibitor. And the first one of that was zidovudine. And so these are nucleotide analogs. So zidovudine, for example, is a thymidine analog. Do you see that? Like the T, or there might be a cysteine analog, like the C. And so what happens is as reverse transcriptase is making copies um, of, from the DNA that's been integrated um, into the human DNA. These drugs are nucleotide analogs, and they come and they get put in by reverse transcriptase into as it's making copies, and they cause chain termination. Okay, so these are nucleotide analogs, and they're relatively weak as antiretrovirals. So usually we have to use two of them in combination. But again, it's just working on one site. So then we would have to combine them. If it's one or two, we would have to combine it with another agent from another class. So the NRTIs come from, or they block reverse transcriptase, and they're nucleoside reverse transcriptase inhibitors, because they're nucleoside analogs. The next class that came out were protease inhibitors. They're on the right. So the first one to come out was ritonavir, and then there was indinavir and sequinavir, and you had to take like 6 pills a day of those, plus the NRTIs. And the protease inhibitors have a lot of side effects, particularly gastrointestinal, so nausea, upset stomach, diarrhea, also metabolic, so like cholesterol abnormality. So a lot of them have been discontinued. So you can see there with the ones that are crossed out. And really the only one we still use is darunavir there, which is bolded. And this class of drugs, protease inhibitors, that you have to take so many pills because there's not, when you take it orally, um, not enough of the drug level ends up in the blood or in the where it needs to go in the cell. So actually what we do with these drugs is we do something, we boost them. We use the ritonavir, which is a protease inhibitor, to block, it blocks cytochrome P450. If you remember back to your pharmacology, uh, um, uh, pharmacodynamics and metabolism. So ritonavir blocks cytochrome P450, which reduces the metabolism of these drugs. So then the darunavir concentration, for example, will be higher. So so then these drugs would be, we would use them boosted, and they would be called a boosted protease inhibitor. And then now we have darunavir with another booster called cobicistat, and it comes in one pill. Darunavir and cobicistat in one pill, um, which is Prescobic. So the trade name for darunavir is Prezista, and then so darunavir with Prescobics in one pill, and cobicistat in one pill is called Prescobics. So of the NRTI class there, typically the ones that we use still would be tenofovir there at the bottom, TDF. We have a new version of it called TAF, tenofovir alafenamide, which is a new formulation of tenofovir. And we use it in combination with emcitriptine, which is FTC. And so tenofovir and emcitriptine in one pill is called Truvada. So, but that's acting at one location of the replicative cycle. So we could use a combination, for example, Truvada plus Prescobics. Do you see that? Because we have the Truvada acting at the one site of replication, and then the darunavir or Prescobics is acting, and it's a protease inhibitor. It's blocking protease, which is at the end when it's putting all the stuff together to kick out of the cell. And so these drugs came out, the NRTIs came out in like 1991, 93, and then protease inhibitors came out in 1996. So 30 years ago. And it was like the day that the study was shown at it was actually in Vancouver at the World AIDS Conference 30 years ago, which showed the response of triple therapy. And at the time we called it highly active antiretroviral therapy. Changed everything. So then the next class that came out in around 1999 were non-nucleoside reverse transcriptase inhibitors. So again, it works at the nucleoside reverse transcriptase. So the reverse transcriptase, but it's a non-nucleoside. So it's not like an thymidine or a cysteine analog that causes a chain termination. These ones work directly at blocking and stopping reverse transcriptase. Do you see that? And so what we'll use, for example, is two NRTIs, so like tenofovir and emcitriptine, so TDF and FTC, with an NNRTI. So you can do that. So those are even considered two separate classes. And the thing that was popular about NNRTIs is that they were better tolerated than the protease inhibitors. So the ones sort of closer to the bottom, the doravirine and the rilpivirine, are the ones that we use more commonly today. And the first single tablet regimen that came out was tenofovir, emcitriptine, which is FTC, with efavirenz, which is the second one there, and it was combined into one pill, those three drugs in one pill, and it was called Atripla. Then the fourth class that came out, which came out around, I think I would say 2003, and we discovered these entry inhibitors, fusion inhibitors, and Fuvertide was given by injection, and it blocked GP41, so that needle, and we don't really use it anymore because it's by injection twice a day. Maraviroc is a CCR5 inhibitor, so and that was actually discovered by assessing long-term non-progressors, elite long-term non-progressors, and it was found that there was a mutation with a delta deletion in the chemokine receptor, and these people um, basically acquired HIV, but no effect on them. And so it was actually through that population that we discovered that mechanism of that requirement of attachment to a chemokine receptor, and Maraviroc was um, uh, created in the lab. But we don't really use those entry inhibitors, fusion inhibitors, very much anymore. Each of these classes in particular have a class-specific side effect. So what gets complicated in like in healthcare in HIV is that you have to know all these drugs, you have to know all the names, you have to know which ones are in combined pills, and then you have to know the side effects. So each class of these have side effects. I already told you protease inhibitors have GI side effects like nausea, diarrhea, metabolic, so like high cholesterol, diabetes. NNRTI, the class-specific side effect is rash. And then the NRTI side effects is mitochondrial toxicity. So because they're nucleoside analogs, they actually also block mitochondrial DNA polymerase. So mitochondria has their own little, I don't know if you know, but mitochondria make their own DNA and using DNA polymerase. And so the NRTIs can affect DNA polymerase, block DNA polymerase, and so can cause mitochondrial toxicity. So those NRTI class are potentially a little bit more toxic. And then you also have to know each drug on its own might have its own drug-specific side effect that you need to know about. So for example, tenofovir there at the bottom, which we still use today, accumulates in the proximal renal tubules to get excreted, and so it can cause kidney problems. So we have to follow the kidney function for that reason. So that's what is hard about and the steep learning curve to understand antiretroviral therapy. The big change in HIV came when this class became available, integrase inhibitors. The first one was called raltegravir, which came out in about 2005. And it was a pretty incredible time because we had people who had never had a undetectable viral load, and we had raltegravir and we had darunavir, which at the time we would have boosted with ritonavir, and we had enfuvertide, that GP41 blocker, come out at the same time. And so we were able to put people on, and actually an NNRTI, you can see there, etravirine also came out at the same time. So we had these four drugs come out at the same time, and we could clearly, like, it's the same concept. If you need 2 to 3 drugs working on 2 separate uh, sites of the replicative cycle, if people have drug resistance or failure, you would need 2 to 3 completely new drugs working at different sites. Do you see that? To be active. So it allowed us to create those kind of regimens for the first time, which was amazing. So the first one to come out was raltegravir, which is given twice a day. Then elvitegravir came out, but needed to be boosted. So it's boosted with cobicistat and is only available in 2 single tablet regimens. One's called Genvoya, which has TAF and FTC, elvitegravir and cobicistat. And then the older one is Stribild, which had TDF instead of TAF. We don't use it a lot anymore. I like it because it's very well tolerated. But then the next one to come out was dolutegravir. trade name is Tivicay, and it comes in a few single tablet regimens. So dolutegravir can be with, the first came out with abacavir and lamivudine, 3TC, with dolutegravir, and that was called Triumec. And then now we have uh, two drug regimens with dolutegravir, because dolutegravir is very potent antiretroviral. So you can, with it, when dolutegravir is with lamivudine 3TC, it's called Dovato. And if you get there, before Dovato even came out, another two drug regimen came out where where the dolutegravir was combined with rilpivirine, which you can see as the second last one in the NNRTI, and that is called Jaluca. And then it gets complicated because rilpivirine needs acid in the stomach to be absorbed. So rilpivirine has to be taken after eating food. So, the different, even the combinations, you have to know little tricks about their metabolism. So then after dolutegravir, bictegravir came out and is only available in a single tablet regimen in Biktarvy. So that's TAF, FTC, and bictegravir in a single tablet regimen called Biktarvy. And then the last integrase inhibitor that has been released and that we use is called cabotegravir, and that's the one that is in the injection. And so in the injection for the treatment of HIV, one of the drugs that is injected is cabotegravir, so it's an integrase inhibitor. And so we need a second drug, right? That is acting at another replicative site. So the one we use is rilpivirine. Again, rilpivirine, because it can be long acting by injection. So for the treatment of HIV, we use cabotegravir and rilpivirine, and that's called Cabnuva. And then cabotegravir alone for the prevention of HIV is called Apretude. And then even more drugs came out in entry inhibitors. I put those on the first slide, but some other ones came out like fostemsavir, ibalizumab. And then the latest drug to become available is a capsid inhibitor called Lenacapravir, which is given by injection every 6 months. And is also been approved by Health Canada for prevention. And we can't use Lenacapravir for treatment of HIV alone, right? Because obviously we need more than one drug working at different sites of replication. And the other thing that you have to know about these different classes of drugs and the different drugs themselves is that each of the classes have different ways and standards and levels of developing mutations, drug resistance. So the virus develops drug mutations only if someone is taking their medications, but they're non-adherent, so they're not taking enough of the medication. And so the drug level is not high enough to suppress the virus. And so you have substandard drug levels. And it's not like the virus is smart. What happens is the virus is going to replicate, and the virus makes mistakes in its nucleotide insertions. And so it makes mistakes in nucleotide insertions every one in like a million, 1 in 10 to the 6. And it doesn't have mechanisms to correct those mistakes. Like the human body, we have, I don't know, 6 or 7 or 8 different mechanisms to correct genetic mutations. The virus doesn't have any. And actually, this is like all viruses. This is why viruses mutate. So it's natural. Viruses mutate, and then the virus where the mutation confers a benefit. So for example, with COVID, that benefit was increased transmission, right? So the virus with the mutation that has increased transmission, well, that's the virus strain that is going to be spread around to everybody. Do you see that? And then with the HIV virus, the mutations that confer benefit are the ones that where the virus has mutations that prevent the drugs from working. So that's how that happened. That's how drug resistance happens. And every class has a different sort of pattern of drug resistance. So we have some drug classes that have low barrier to resistance, so they develop mutations very quickly. So that's like the NNRTI class. Um, or we have some classes that have high barrier to resistance. So like protease inhibitors. We liked using protease inhibitors because people could miss their doses, but the virus didn't develop drug resistance. Do you see that? And then the NRTIs are kind of in the middle. And then some of the mutations that develop um, confer drug resistance just to the one drug. And then there's other mutations that develop that confer drug resistance to the whole class. And which pathway they go down is interesting and why they do that. And so if anybody is interested in virology and drug resistance, it's very interesting. But so you see that sort of adds another complication and sort of level of um, complexity to understanding the use of antiretroviral drugs is what are the resistance patterns of the different classes and drugs. The integrase inhibitors in terms of drug resistance, raltegravir has a low genetic barrier or medium, and so does elvitegravir. But the really amazing thing that came out is dolutegravir and bictegravir have a high genetic barrier. So high barrier to resistance, almost like a protease inhibitor. So that's why we use a lot of bictegravir and dolutegravir based regimens. Cabotegravir, which is the injectable, has a lower genetic barrier, and Lenacapravir has a lower genetic barrier. So you can't just use Lenacapravir every 6 months alone because the virus will develop drug resistance. Do you see that? And so if you're going to combine Lenacapravir as an injection, it would have to be done with other antiretroviral drugs. One of the things we're doing for people who don't like taking pills is we're combining Cabenuva, so cabotegravir and rilpivirine, with Lenacapravir. Do you see that? Okay. Um, I think that's a lot about antiretroviral drugs. I think we're doing okay. Any questions so far? I know it's a lot of information. So the terminology for antiretroviral treatment is we call it first line treatment if a person was diagnosed with HIV and they've never taken treatment before. And we call that person antiretroviral naive. So if we're doing a study or a trial, it's an antiretroviral naive trial, meaning we're testing giving a drug regimen for the first time, comparing it to the standard of care. A second or third line treatment is if a person gets their second or third line antiretroviral treatment, and it can be due to they could have virologic failure, so they're non-adherent and the virus has drug resistance, but it can also be due to side effects. And in that, or we can do studies where we're switching them. So we're like they're on an antiretroviral regimen and their viral load is suppressed, and we're doing what's called a switch study to see like for example, we're doing one now where people are suppressed and we're going to test. We have Cabenuva every 2 months versus a new formulation every 4 months. So those people are actually antiretroviral experienced. Do you see that? But it's a switch study. So so it can be just they're already on it, or it's due to side effects or virologic failure. I use the American guidelines, the Department of Health and Human Services guidelines. You can have a look at them. They're like 600 pages. If you read them, then I swear, if you read these guidelines, you'll know how to manage HIV. So if this is the field you want to go into, I recommend reading those guidelines. When you come to my clinic, I give you the handout of the International Antiviral Society USA guidelines because it's only about 8 or 10 pages. And each guideline is a little bit different from each other. There's also the European AIDS Clinical Society has guidelines that's updated every 2 years that are also a little bit different. And in Europe, they're very much influenced by price. The British HIV Association guidelines have guidelines, and then the WHO have guidelines that are more geared towards mid and low income countries. We do not have guidelines in Canada. I think Quebec has guidelines and BC has guidelines. So the benefit of Canada is we just say we can use any of these guidelines. So we kind of pick and choose. We sometimes we use the DHHS, we use Europe, so we kind of fit in everywhere. So we typically need three active drugs at once, which I talked about from two different replicative sites. Action, so from two different classes. Typically, historically, in what we called first line treatment, we would use two NRTIs. So TDF FTC, which is Truvada, abacavir or 3-TC, which was Kyvexa, which we don't really use anymore, or TAF FTC, which is Descovy. And then we would combine it with a third agent. So most commonly now an integrase inhibitor, but I told you about protease inhibitors like darunavir with ritonavir or darunavir with copacetat, which is Prescobex, or an NNRTI, rilpivirine. Nevirapine, we have a bit in our clinic still. It's like a legacy drug, one of the first NNRTIs that doesn't have a lot of side effects. So we might still have a few patients on that. Or the latest NNRTI uses doravirine. And we used fixed dose combinations. So as I said, the TDF 3-TC, or actually it's TDF FTC, sorry, comes in Truvada, abacavir 3-TC is Kyvexa, TAF FTC is Descovy. So we'll use those so that instead of, for example, if we had tenofovir separate from FTC, separate from darunavir, separate from ritonavir, that would be 4 pills once a day, but we can combine Truvada and Prescobex, and it's just 2 pills. Do you see that? Or we use Truvada with dolutegravir, Tivicate, 2 pills. We do have three new single tablet regimens, or 3 new regimens that are 2-class regimens. So I already told you about that. Dolutegravir with rilpivirine is Juluca. Dolutegravir with 3-TC is um, is uh, um, is Dovato, and then cabotegravir rilpivirine is Cabnuva. And so that is actually a bit of a paradigm shift in the last 5 years, where actually we feel pretty good now that we can actually use 2 drug regimens, 2DD, 2DR, I mean, 2DR, and they work just as well as 3 drug regimens. We like to use single tablet regimens. There's 10 different single tablet regimens. The most common ones used are Biktarvy, which is TAF FTC, Bictegravir, Dovato, which is dolutegravir 3-TC, and then we sometimes use Delstrigo, TDF 3-TC, doravirine. It might be associated with less weight gain. And then you can see the other ones there that we might have people on here and there. The most important thing for treatment is someone's readiness. I have rarely had a problem. We do something called rapid starts now, whereby so for example, we had actually I got a text and we have a new case, and I'll see that person on Monday or Tuesday, and we'll do the blood work, and I might even start like Biktarvy or Dovato even before getting the blood work back. That's called a rapid start, because some studies have shown that the sooner you start the antiretroviral regimen, the more people are likely to continue in care. And that's like to support ongoing retention, and we want adherence to be 90% or higher. The goal of therapy is virologic suppression, so which is defined by a viral load less than 40, immune restoration, so we want that CD4 count to go up, and it continues to go up over 5 years. By being adherent and having a viral load undetectable, that means that the virus is not replicating, so that prevents drug resistance. Do you see that? So that's very important. Decrease morbidity, decrease mortality, decreased opportunistic diseases and infections, better health and well-being. And then you've probably heard of U equals U, undetectable equals untransmittable. So, and also known as treatment as prevention. So getting people, and that's like another reason to do rapid starts, is getting somebody engaged in care and getting on treatment as quickly as possible. Because if the viral is undetectable, it's untransmittable. So that's known as treatment as prevention. And basically now the guidelines say that we should be treating everybody, no matter what their CD4 count is. In the old days, we sometimes, when the drugs weren't as good, we would wait till the CD4 count was below 350 or 200. We don't do that anymore. We start everybody. There are some urgent situations like pregnancy, acute opportunistic infections, and AIDS-defining illness, rapidly falling CD4 count, HIV kidneys disease, which is called HIVAN, HIV-associated nephropathy. If someone has active hepatitis B, the drugs Truvada and Descovy also treat Hep B. Active Hep C, you might want to get started on the HIV treatment before we treat the hepatitis C. And we like to treat an acute HIV infection as much as possible. Because if we do that, it's amazing. The immune system's able to be restored. So I have a few more slides that I added in that I thought you'd be interested in. I think I have time on pregnancy and HIV. I know a few of you had asked about that. So I'm going to go over that. Interestingly, the slide doesn't show up very well, but I don't know if you know, but the majority of the transmission of in pregnancy happens at the time of labor and delivery. So only 20% of the infections of HIV from the pregnant person to the fetus, which is called in utero, that transmission happens only in 20%. And if it does happen, it would tend to happen when the person who's pregnant gets infected during, like they're already pregnant and then they get infected while they're pregnant. And then you can see what happens is they get acute HIV infection, the viral load goes sky high, and then that's when transmission happens to the fetus. So, so really you can see there in the non-breastfed person, let's look at the lower bar graph. Actually, 75% of the transmissions happens at the time of labor and delivery. And that's because of the secretions and the blood but this is with if the person who's pregnant and delivering is not on antiretroviral therapy, okay? So, of course, we want to get them on antiretroviral therapy with a suppressed viral load as soon as possible. But if their viral load's not suppressed, actually, by the time they get to labor and delivery, we can actually do cesarean sections, and that reduces the chance of transmission. Isn't that interesting? Because you're preventing the infant from going through the birth canal with all the blood and secretions and all that. So cesarean section reduces the risk of HIV transmission. And then you can see on the top sort of graph that breastfeeding in the context of not being on antiretroviral therapy adds an additional sort of 30% risk of HIV transmission. This was the first study. Oh, actually, the first clinical trial in HIV was actually a clinical trial of the use of zidovudine in pregnancy versus no treatment, and it reduced HIV transmission by like 80%. And that study came out in 1994. So it actually came out before the highly active antiretroviral drug clinical trials that I talked to you about with protease inhibitors in 1996. So the first big breakthrough in HIV treatment was actually in pregnancy, where we knew that giving even just one drug, even zidovudine, it reduced transmission by 80%. And then this cohort came out from Chicago and the WITS cohort that showed that if the viral load is less than 1,000 at the time of delivery, there was zero chance of HIV transmission to the infant. And we actually use that number until today, that the viral load less than 1,000 is the cutoff for if the viral load is above 1,000, then we do a cesarean section. And then in over the years, the French perinatal cohort study has shown that they follow all mother or parent infant pairs, and of 5,482 who were on antiretroviral therapy with fully suppressed viral load before conception, which is before pregnancy, and suppressed during delivery and didn't breastfeed, there were zero cases of perinatal transmission. So U=U applies to pregnancy if the person suppressed on antiretroviral therapy before conception. And I do use the term zero. Intrapartum, it discussed that we can use cesarean sections to decrease perinatal transmission. And if the viral load is greater than 1,000, we would book the cesarean. We want an elective cesarean section. So if it's non-elective, so it's like an emergent cesarean section, it will it doesn't reduce the risk of transmission. So we schedule the cesarean section at 36 weeks. What about postpartum period infant feeding? In Canada, the recommendation is for formula feeding is to not breastfeed because till today we don't have the completely appropriate studies to say that U=U applies to breastfeeding and chest feeding. So the Canadian recommendation is for formula and to not breastfeed. But if a person does want to breastfeed or chest feed in optimal circumstances, meaning viral load is undetectable, preferably before conception, throughout pregnancy, and after, and they agree to be followed monthly, and then the baby is given medication, antiretroviral therapy, then people can be supported to breastfeed in Canada. And if you're interested in infant feeding and HIV, and if you're interested in breastfeeding and HIV, let me know. We have a couple of projects that I need help with. So, but this is the main study of that. It was so interesting. It was done in Africa, where they enrolled 2,392 mother-infant pairs after delivery. So the randomization actually happened in the postpartum period. They all breastfed, and half of them received maternal antiretroviral therapy, and the other half, the infant, received just infant nevirapine. And the outcome was transmission from breastfeeding. And you can see there that the transmission is the same in both arms and low. But there were 2 infants that were infected from breastfeeding in this study in the first arm, like with the triple therapy, with the viral load being undetectable. These are the 2 cases. And what you can see is that actually their viral loads were not suppressed at the time of starting to breastfeed. And that's relevant. And actually, the US guidelines just changed on June 25th, 2026, to actually say that to give the options equally of or equivalently of formula feeding, breastfeeding, or donor milk if if the viral load is undetectable for at least 3 months before conception. But in Canada, we still recommend formula feeding and not breastfeeding as first line. There's a video I made. It's old. It's from 2018, but it still applies for the counseling of infant feeding in Canada. And actually, Ari Bitnam, who's pediatric ID, who I have a lot of respect for, we work together in cases where parents want to breastfeed, and we wrote this blog which is a step-by-step process to support people who want to breastfeed. And that's it.